Hello, good afternoon to all of you. First of all, I would like to thank you very much for inviting me to this really great event. It's really great honor for me to share with you some thoughts and experience regarding, I think, extremely important topic. What can we do for patients with the worsening heart failure event? These are potential disclosures related from my side to this presentation. When we think about heart failure, it's extremely important to consider this disease not as a stable condition. There is a certain journey that all patients has to go through, starting from the development of heart failure, coming to the baseline risk and development of heart failure. And finally, something extremely important, when we implement certain drugs for the heart failure, the baseline risk does not go to zero. Still, there is residual risk. It means that sooner than later, our patients will decompensate, will experience worsening heart failure, which in many cases will lead to heart failure. And the final step of all these worsening events leads to the advanced heart failure and, unfortunately, inevitable death of our patients. Something which is very important in this journey are all those worsening heart failure events. If you look at this curve, you can see that after worsening event, patients never come back to the previous status. In fact, each worsening event leads to the step-by-step progression of heart failure. How do we diagnose this worsening heart failure events? Definitively, this is the situation where we have progression of signs and symptoms of heart failure, even though patients seem to be optimally treated. And this situation usually needs either the use of IV diuretics or significant increase in oral diuretics. In many cases, the patients are hospitalized, but not always. We also see that sometimes these patients can be seen at the emergency department. And usually, as you can see, after this event, either this is the hospitalization or this is this visit at the emergency department, it's related with the poor outcome. And the more hospitalizations, the more worsening heart failure events, the worse outcome, translated as the very, very high mortality. And many people think that hospitalization is really bad situation, but not all of us really appreciate the prognostic significance of the emergency department visit when patient is admitted and treated. Please look at the data which we have, for example, from the MADIT CRT and the Paradigm HF trial, which clearly shows that even the heart failure hospitalization, emergency department visit, and even the outpatient worsening heart failure translates in very high all-cause mortality. Something which it's also very important to emphasize is that we have more and more hospitalizations. The number of his hospitalizations increase over the time when heart failure develops. And something which needs to be pointed out is the situation that we have a certain group of patients who have really multiple hospitalizations. Therefore, there is the huge need to help these patients and to implement the proper treatment. We also have to say that we are very, very lucky that we have already quite established treatment. We have ARNI, we have SGLT2 inhibitors, MRAs, and also beta blockers, which definitively reduce the risk of heart failure hospitalizations and cardiovascular mortality. But please have in mind that even though we use this treatment in our patients, their baseline risk does not go to zero. Still, there is significant residual risk in our patients, and they always, even though they receive the 4 fundamental therapies, there is still the high risk. Therefore, if you look at the central figure, which comes from our 2021 ESC guidelines, we can clearly see, first of all, that there are 4 fundamental therapies that are recommended to be used in all patients with heart failure and reduced ejection fraction. But please have in mind, this is not the end of this table. Obviously, it's important to emphasize that all these 4 drugs should be used because in comparison to the old conventional therapy as ACE inhibitors and beta blockers, we can save lives to our patients. And this survival effects are seen across the age, and also people who are very old can benefit from this treatment. But as I have said, this is not the end of this figure. And this is because even if we use all this pharmacological armamentarium, our patient still may be decompensated, still may die, and still may experience symptoms. Therefore, there are certain treatments for these patients, and among these treatments, the vericiguat is a very, very good, safe, and beneficial option. Importantly, Victoria trial was designed in this patient population, patients who have heart failure and experience worsening heart failure events, considered as either recent heart failure hospitalization or outpatient use of IV diuretics. Ejection fraction was below 45%. And as you can see here, all the patients were requested to be treated using modern life-saving therapies. Something very, very important, eGFR equal or above 15 mil per min per 1.73 square meters. Importantly, also patients with severe heart failure, severe kidney failure were included in this trial. And also something very important, around 11% of these patients were included to the trial when being in hospital. So if you look at the cohort of patients in the Victoria trial, you can see that there were patients at the very, very high risk. Primary endpoint event rate, as you can see in the control arm, was extremely high. 40% of patients either being hospitalized or being deaf due to cardiovascular death. Very, very high NT-proBNP level, being the reflection of really high-risk population. And what was demonstrated? First of all, please have a look at the primary composite, which is cardiovascular death and heart failure hospitalization, evident risk reduction with absolute risk reduction of 4%. Importantly, I would like also focus you on the total heart failure hospitalization. Extremely clinically relevant endpoint. This is the problem that we have currently. Many heart failure hospitalization, huge burden, and it looks like that we have the drug which can deal with this problem. Again, as you can see here, Victoria trial was the cohort with very, very high risk, and that's why the absolute risk reduction was very, very important and very highly achieved. And as already mentioned, the whole cohort of the Victoria trial, in fact, included patients who were hospitalized up to 6 months, but there were also patients who were hospitalized more recently, and also some patients who received intravenous diuretics in the outpatient settings. As you can see, regardless of these tiny differences, how we would define heart failure worsening, the benefits due to vericiguat were clearly seen in all these groups. Also, if we look at the patients who were treated with ARNI or not, clearly again, the homogeneous effect, regardless whether patients were receiving this modern treatment. Many people may worry that this treatment may affect kidney function. Completely no signal that there may be any risk regarding the worsening of kidney function. And also something very important, this drug, there may be some tiny risk that this treatment may cause lowering blood pressure. However, importantly, please look at the subgroups where changes in the blood pressure were demonstrated in patients younger versus older, in patients who had higher or blood pressure lower than 110, and also those which used to be treated with sacubitril valsartan. Please particularly look at the patients who had systolic blood pressure below 110. As you can see here, virtually no drop in this blood pressure. Only in those who had, let's say, blood pressure above 110, there was tiny decrease in blood pressure. However, this decrease was seen at the similar extent in both study arms. So I think we have quite clear evidence that vericiguat is safe, and vericiguat is also very, very effective in this patient population. Previous episode of worsening heart failure and with the baseline treatment of life-saving drugs. Therefore, as you can see here, there is strong recommendation to consider this treatment on the top of 4 fundamental therapies. How to do so? Being the group working in the Heart Failure Association, together with Giuseppe Rosano, we developed the patient profile concept by using very simple clinical profile measures like blood pressure, heart rate, kidney dysfunction, atrial fibrillation. We propose to implement not just these 4 fundamental therapies, but also other therapies, including also comorbidities and baseline cardiovascular risk, which is extremely, extremely important, particularly in the context of adding vericiguat, which brings survival benefits to patients who are particularly at very high risk of heart failure hospitalization. As you can see here, vericiguat should be considered in different clinical scenarios. In patients who have rather low heart rate, there is no risk of bradycardia. In patients with blood pressure, which is higher, also there is no risk that vericiguat may augment hyperkalemia. So this treatment also is safe in these patients. And obviously, we also have evidence that this treatment can be used in patients with GFR up to 15. So definitively, the big high-risk population of heart failure patients with kidney dysfunction also can benefit from vericiguat therapy. So as I have said, at the moment, we have the huge population of patients with heart failure, and we should consider patients who seem to be stable, not to be stable, in fact. Please have in mind that all patients with heart failure, even though they are on the optimal life-saving therapies, they will decompensate sooner than later. And definitively, we should do something very, very quickly using other treatments like vericiguat to prevent these events. Thank you very much for your attention.